Okay, welcome to EuroPCR 2023. We've got a packed house here. It literally is standing room only. And I'm Andrew Sharp. I'm a consultant cardiologist from Cardiff in the United Kingdom. And it's my great pleasure to have an expert panel with me. On my right here, we have Flavio Ribicchini from Verona, a great expert in renal denervation, amongst many other things, a true Renaissance man. So welcome, Flavio. We have Atul Patak from Monaco, an expert in hypertension amongst many other things. And next to him we have Felix Mahfoud, who has led many of the papers that we've seen underpin the evidence in this field. We will be joined by Professor Bruno shortly, and I'll introduce her when she is here. So first of all, what we're going to do is just talk about the session objectives. This is going to be quite short, and then we can get into the meat of things. These are my conflicts of interest. Okay, so most importantly, hypertension is the #1 cause of death worldwide, the #1 avoidable cause of death, and quite bizarrely, despite being obviously the most important condition in medicine, because it kills more people and harms more people than any other condition, it's very badly managed. It's only controlled in about 45 to 55% of patients in different countries around the world, whether that's the richest of countries or the poorest of countries. And that's why all of us are in this space, because we need new treatments. We're not getting rid of the old ones, we're saying we need new ones to come on top. So World Hypertension Day is about trying to get the message out, because there are many physicians who don't realize that if you reduce blood pressure by 2 millimeters of mercury, you reduce the risk of stroke by 10%. And I guarantee there'll be half of this audience who thinks, no, that's not right. But that's been proven in a meta-analysis from Lewington and The Lancet. Blood pressure reduction is an enormously powerful thing, and we've got to get the message out. So if you scan that QR code, and then you either like, share, or comment on the article, Medtronic's deep pockets are going to fund the International Society of Hypertension to try and get the message out, to try and spread good hypertension care around the world. This is not a device thing. This is about trying to improve hypertension care. So please scan that code and contribute to hypertension development around the world. And as I mentioned, it is extraordinary. When you think about the force and the power that the world brought to bear against COVID, a condition with a fatality rate of around 2%. That killed about 1 million people in 2020, maybe 1.5 million on death certificates, and then in total about 3 million people. That's how many are dying from hypertension every year. And yet we haven't solved this problem of hypertension that affects 1 in 4 of all men and 1 in 5 of all women, with only half of the patients getting treated to control. And that's to a weak control standard of 140/90. That's not to the new European and American standards of 130/80. So we're here to talk about devices. We have changed almost everything in this procedure, and our re-understanding of this space in the last 10 years has been enormous. And so what we're talking about here is what some people call the comeback kid, a technology that started off as a relatively simple procedure with limited anatomical understanding. We've now enriched our understanding to realize that the renal sympathetic nerves are wrapping around the bifurcation and the first order branches of the renal artery. Previously, we had a single point catheter. We focused on the ostium. Now we're focusing around the bifurcation and more distally. We are able to now show in several sham-controlled trials with different technologies that we have a device that is proven to lower blood pressure. And I think that's crossing a Rubicon. That is taking us forward into a new era of hypertension care. So much so that we've got 2 new consensus documents in the last 2 years, one from the European Society of Hypertension and one from the European Council on Hypertension in association with the EAPCI who run this conference, showing that everything has moved on. There was rightful skepticism in the 2010 decade. Now we've got 6 positive sham-controlled trials, 2 technologies, and there's acceptance that this now has a role. And these 2 consensus papers emphasize that this should now be considered as part of mainstream management of hypertension care, in addition to pharmacology and in addition to lifestyle, both of which remain critical in the management of hypertension. Okay, so what I'm going to do is I'm going to let Felix expand more on what we talked about the devices and the results that we've got. Felix, if you wouldn't mind taking the podium.
Thank you very much, Andrew, and good afternoon. It's a great pleasure to review the evidence on efficacy, durability, and safety of radiofrequency renal denervation in the next couple of minutes. These are my potential conflicts of interest. Well, I think it's important to recognize what has been accomplished in the field of renal denervation. We have a lot of evidence aggregated in the past few months and years about the safety and durability of renal denervation. And you see it here. So after the publication of HTN-3, colleagues from the United States and from Europe designed new randomized sham-controlled trials. And it all started with a spiral HTN off-med pilot study, so a trial in patients who were not receiving any concomitant antihypertensive medication. We expanded this by an on-med study where patients on 1, 2, or 3 drugs were included. And then we have a pivotal study, which is important to recognize too. The whole program was designed to confirm the blood pressure lowering in patients not taking any antihypertensive drugs. And indeed, this is considered the US FDA pivotal study. And there is a spiral HTN on-med full cohort, which I will discuss with you in the next few slides. Of note, and this is particularly relevant when it comes to safety of renal denervation, we have also to acknowledge that we performed more than 20,000 procedures with the spiral system now around the world. And this speaks to its safety, but also speaks to its utility in clinical practice. I shared it already. We have different studies, different trials. All of them were designed and powered for efficacy endpoints, for safety, first and foremost. And you can see here again that the off-med study, the pivotal study, was conducted in patients not receiving any antihypertensive medication. The prospective on-med trial used renal denervation in patients treated with antihypertensive medication. And we have an important data source, which is the Global Simplicity Registry, where more than 3,300 patients are included now. And this is being used for long-term assessment of renal denervation's safety and efficacy. So this slide here is a high-level summary of the major outcomes for 24-hour systolic blood pressure, as shown here in the different studies of Med Pilot, where you can see and appreciate very nicely that indeed the renal denervation group had a larger fall in blood pressure than the sham group for 24-hour systolic, but also for office blood pressure. We expanded this into the off-med pivotal study, again, which is submitted to the US FDA. 4.7 millimeters of mercury here in 24-hour systolic, 9.2 in office diastolic. We had an on-med pilot study in patients on antihypertensive medication, which kind of duplicated the results we had seen in the presence of antihypertensive medication, 9 millimeter fall in blood pressure in the 24-hour blood pressure, and here 9.4 in the office. And then there's a kind of outlier, which is shown here on the right-hand side, which is the on-med full cohort. So an extension to the pilot trial where more patients were included from different centers, particularly in the United States and in Europe. And you can see that the denervation effect was pretty much the same. Here, 6.5, 9.9. But what is larger than expected, significantly larger than what we expected, is the sham drop here in patients treated in this study. And I think it's important to discuss that in more detail. So it's not the renal denervation effect that we were concerned about, but the sham effect that was larger again than expected. So what's the cause for this sham drop? And thanks to toxicological analysis, we know what patients were doing in this study. Unlike in HTN-3, where we did not systematically assess adherence to medication, you can nicely see that patients treated with sham with an invasive placebo in this study had an up-titration in medication. It increased from 3 to 3.5, which was significant, and medication in the renal denervation group remained stable. And this may be the most relevant observation explaining the larger than expected sham effect. And again, looking more in detail into what happened in this study, I think it's also important to acknowledge that there are differences in patient care around the world. And when you look into this subgroup analysis now, you can also appreciate that obviously outside the United States, like in Europe, where we are, a 7.4 millimeter mercury was the drop following denervation, an eligible sham effect, 2.6. The difference here was statistically significant. When you then look into US patients, US Black patients, self-identified as Black, you can appreciate that something went wrong in these patients in terms of medication escalation. So we had a significantly larger sham drop than the renal denervation drop. 8.7 millimeters of mercury was the fall observed in sham. So it's not that this technology is not working. Indeed, it suggests that there were up and down titration, particularly intensification of antihypertensive medication in US Black Americans. We know that antihypertensive drugs can provide bias to any study. It can confound the outcomes, which is why we have run these off-med studies and which is why we believe it is the pivotal study to look into patients who are not receiving any concomitant antihypertensive medication. That's the purest population you can think of. When you look into these patients here in the absence of medication, so we confirmed by toxicological analysis that they were not treated. There is an hour-by-hour larger fall in patients receiving denervation as to sham patients. And that speaks to the efficacy of this procedure in the absence of drugs. And you see the same here on the right-hand side in the presence of medication. But again, this is kind of confounded in some patients in the sham group, particularly who had an intensified antihypertensive drug regimen. It is safe, which is particularly important when it comes to mild to moderate, low-risk hypertensive individuals that we may want to treat using renal denervation. It's very safe. We had a performance goal agreed and set up with the FDA to be below 7.1%, and you can see here that it was 0.4%, so very low adverse event rates. We only had one vascular complication here in one individual treated in these studies. What about renal function? That was a concern very early expressed, particularly by nephrologists. You can see here that we're closely assessing renal function in the Global Simplicity Registry in thousands of patients. And again, displayed here is that there is no significant change. It's within the expected range of a difficult to control hypertensive patient population. Renal function remains stable, and particularly looking here, into patients who had a CKD at baseline, KDIGO stage 3, so eGFR below 60, you can see that there is no significant drop observed in eGFR. How long are these blood pressure drops persisting, sustaining? That's an important question. Is there reinnervation occurring? And I guess these data here speak for themselves by showing that out to 3 years, there's a significant larger reduction in patients treated with renal denervation as compared to sham-treated patients. And now we're seeing the drops that we want to see. Indeed, long-term, when we manage these complicated patients, we're talking here about 19 millimeters of mercury and 24-hour systolic blood pressure. And here an office blood pressure fall of 21. Not shown here, but particularly important is the drop, the larger, proportionally larger drop observed in nighttime blood pressure, which is closely associated with cardiovascular outcomes. And again, here also 20 millimeters of mercury changes were observed. When it comes to control rates, and this is relevant in clinical practice, I guess, we do see that patients who are treated with renal denervation has almost doubled their control rate, 83% as compared to 44% in this randomized sham-controlled study. Indeed, I'm talking here about the Spiral HTN ONMED pilot study, where we graded a systolic blood pressure below 140 in 24 hours as a control, and this was twice as high in patients receiving renal denervation as compared to sham treatment. Long-term, outside of clinical trials, in the registry, and this is relevant when it comes to the external validity of the trials, because randomized sham-controlled trials are an artificial environment in highly experienced centers around the world. Patients are carefully selected to be included in these studies, so it's important to look into clinical practice, and we're doing that continuously here in the Global Simplicity Registry. And you can see that in the registry, the blood pressure falls are pretty much in line with what I've shown you from the randomized control trials. Office systolic blood pressure at 3 years, 17 millimeters of mercury, and the corresponding 24-hour blood pressure was 9 millimeters of mercury. A question that is very frequently asked relates to medication in clinical practice, and I'm sure we will discuss that during the session later on. Which patients should be treated with renal denervation in clinical practice? I guess most commonly patients on multiple medication will be treated, and you can see here indeed that we looked in the Global Simplicity on whether the background, the intensification of the background antihypertensive drug regimen has an effect on blood pressure. We graded patients into those who had 0 to 3 drugs prescribed versus patients on more than 4 or 4 baseline antihypertensive drugs. And basically the blood pressure changes are exactly the same, no differences in terms of office systolic blood pressure reduction through 3 years of follow-up. Another question frequently asked, and the paper will hopefully being published very soon, relates to the use of renal denervation in the presence or absence of aldosterone antagonists, which are the fourth line antihypertensive agents to be used in patients with resistant hypertension. So we looked into it. If anything, we see a slightly larger fall in blood pressure observed at 1 and 2 years in patients treated without an aldosterone antagonist, but at 3 years, it's pretty comparable and not strongly indicating that there is not a synergistically better response to renal denervation in the presence of aldosterone antagonists. Again, it's not one study, it's multiple studies, it's multiple registries. This slide here depicts the 3-year and 5-year outcomes of registries carried out around the world, not only in Europe, but also in Asia and in Russia. We do see significant falls, a long term, out to 5 years. And in that aspect, I guess the longest follow-up should also be discussed, which is a study out of Australia and a German study carried out at our institution, where we looked into the very long-term outcomes. Marcus group here, 9 years. We had 9.4 years in 61 and 33 patients. And you do see that antihypertensive medication is not intensified. Indeed, here it remains stable. In Marcus, in the Australian cohort, it was reduced, but still no changes or slight reductions in antihypertensive medication. But there are persistent blood pressure reductions observed out to 10 years almost of follow-up, as 12.1 millimeters of mercury in 24 hours systolic, and here it was 16.2 millimeters of mercury. So in conclusion, ladies and gentlemen, I think the data clearly shows that there is a significant blood pressure reduction observed in both following renal denervation, in patients with and without concomitant antihypertensive medication. It appears to be always on. I've shown you the plot actually where you see that hour by hour following denervation, blood pressure is lower. The major adverse event rates are low. It is a very safe procedure with 0.4% complication rate. It's much lower than what was anticipated. And we have shown that this procedure lowers blood pressure, not only short-term, not only mid-term, but also long-term, which is particularly relevant. And out to 3 years in randomized sham-controlled trials, out to 10 years in registries, there were significant reductions in blood pressure. With that, I thank you very much for your attention and look forward to your questions. Thank you. Sit down.
So thank you, Felix. Welcome to Professor Bruno from Paris, hypertension expert. So thank you for joining us. I think what we're going to do now is we're going to start discussing some topics. We welcome questions from the audience. They can either be delivered via the app to Atul, who's handling the iPad now, who will see your questions, or you can just put your hand up or come to the microphone. Hopefully we'll have a roving microphone somewhere that can hear your voice. But in the meantime, what I'll do is I'll ask Atul to lead off the discussion.
Sure.
We can build on what Felix has said or take any questions that may already have come in.
Maybe a couple of questions while I was listening to you, Felix, and I think it's also important for the audience, the durability, okay? Because how do you explain, first, the feeling that there is an amplification of the effect? So when you look at your figure, you have the feeling that blood pressure is getting lower and lower. And by opposition, do you believe there are some reason to think that there could be regrowth? And there could be some patient where you will see blood pressure increasing and then, because we are playing with nerves. So two questions. First, the durability of effect. How do you explain this auto-amplification? And second, if you have any thoughts about growth after the procedure.
So scientifically, the question is not well answered. We have 3 hypotheses being proposed. One is an interaction with the renin-angiotensin system. We know that renal denervation lowers plasma renin activity. It reduces aldosterone concentrations, and it's likely that there is an interaction between the antihypertensive drugs and the modulation of the RAS system. Number 2, we know that denervation has an effect on total peripheral resistance. So remodeling of a stiff vasculature may take some time to lower blood pressure. And thirdly, there is preclinical data indicating that there is a reset of the barrel reflex, central barrel reflex, and this indeed may trigger a more prolonged effect, a sustained effect, a progressive effect on blood pressure. Okay, so 3 hypotheses, mainly driven from preclinical work, but also supported by clinical data. But there is no single individual pathomechanism that we can attribute the findings to.
This is important for referral and patients. So do not expect a blood pressure drop when you get out from the cath lab or the week after, but it will happen after a certain time, but you could also expect that there could be amplification of the effect throughout the time. And I think this is an important message to not have to fight against physician and patient expectation.
Absolutely. And Andrew, you published a lot on reinnervation in preclinical models. I guess that's in line and pretty much support what we are seeing clinically, right?
It does. So we published in the Journal of Hypertension at the beginning of this year an animal model that showed that if you denervate the renal sympathetic nerves and you do it properly at the initial procedure, that what you get is not just interruption of the axons. The axons, if you imagine them like copper pipe, we interrupted. That downstream from that interruption point, we have a non-myelinated nerve, and therefore that nerve is unable to sustain the infrastructure of the downstream axon. So not only do we interrupt nerve conduction at the time of the original procedure, if we've done it properly, we remove the ability of the distal copper wire to retain integrity, and then it becomes phagocytosed by the Schwann cells that would otherwise attempt to rebuild the nerve. And so even if you were able to jump the denervation spot somehow by reconnecting, you're reconnecting to destroyed tissue downstream. So you're not able to reconstruct and conduct functional nerves after a denervation. Of course, if you don't denervate it properly at the beginning, then of course you may still have integrity there. But if you fully interrupt those axons, then we've shown with various stains looking for particular functional elements of nerve traffic that we are able to do it and do it out to 180 days. And that fits, doesn't it? I mean, in many ways, I'll ask this question to Professor Bruno. As people get older, blood pressure goes up. And we've got 10-year data with maintenance of blood pressure reduction. Are you surprised by that? I thought after 10 years, people would get older, blood pressure would just go up.
It's true. It's even more surprising because Felix just shown us that even treatment burden, drug burden remains the same, indeed, in those patients over 3 years and even over 10 years. So it means if physiology has not changed recently, that indeed the effect is amplified. This is quite clear. And it's so important because we know very well that aging and hypertension has this stiffening effect on large arteries. And so, indeed, the effect of aging is amplified over time because you cannot regress stiffness. When you break the elastin fibers and the collagen is there, you cannot do anything else. So if we are stopping with the process of hypertension early with a functional mechanism, which is the control of sympathetic nervous system, this means that we are in some way, we are stopping the vascular aging, and so we are stopping the progression of hypertension with age, which is fantastic.
It's extraordinary thought, at all.
This is supposed to be a hot topic session. I'm freezing. So I'm asking the audience to ask these questions you never happen to ask maybe in other meetings, because we have these experts, they are talking between them, they are very happy, you know, so give them a little bit of excitement and sweat and just challenge them. So it's starting from the side, maybe Felix or Andrew, is it proven that lowering blood pressure with RDN lower the clinical event? Or is it taken granted that lower pressure means fewer events? So
that's something for Andrew.
Good. Now the temperature is going up. I like it. Okay, thank you.
So it's a great question. So rather than ask me, why don't we ask the US FDA and the EMA? Because what they say is if you bring forward a new treatment for hypertension, the way that you prove it is you do an off-med study. You take patients with mild to moderate hypertension, you take them off drugs. You then test your therapy against a placebo or a sham. You do that after 12 weeks and you demonstrate blood pressure lowering. You then go on to do larger comparative studies or registries to prove safety over the long term. So that's how new antihypertensive drugs are proven, and that's how new devices are proven. So we're just following the model set for modern medications. So why is it that we have to do it that way now? Because the way we proved that ACE inhibitors or even beta blockers or diuretics improved outcomes in the 1980s and the 1990s is we compared them to a control group of patients who were 65 years old, who were smokers, who were obese, who were diabetic, who'd had a stroke before, who'd had a heart attack before. And we left them with a blood pressure of 160, 170 for 5 years. And they had high event rates. And then the ones on drugs had a lower event rate. So we can't do that anymore. Which one of you would put your patients into a control arm with an elevated blood pressure like that, with a high-risk group, the sort of high-risk group you need in order to be able to do a comparative study with enough events? So I think we've shown that salt reduction leads to a drop in blood pressure and is associated with improved outcomes. Other non-pharmacological methods have shown the same. Some drugs have shown the same, although by far from all. There's no outcome data for moxonidine, spironolactone, minoxidil, hydralazine, alpha blockers. We use these drugs for hypertension all the time because they drop the numbers. And dropping numbers by any mechanism seems to improve outcomes. So if we could rewind to 1980, we could test this easily in an outcome study.
But you could do also a trial where you would reduce blood pressure to the target in both arms.
Yes.
Where in one arm you will use renal denervation and other options, pharmacological. In the other arm you will just use the traditional way.
Yeah. So you're talking about a comparative 140 against 140. Yeah. So we've modeled how many patients it would take to do a study like that in order to show either a plausible non-inferiority margin or superiority, and we're in the tens of thousands, which for a device study is difficult. Yeah. If I'm doing a drug study, then I can deliver that study with a research nurse handing a pill. If you want to deliver a device, it's much more complex. 10 people in the cath lab with expensive kit and procedures. The cost of a trial like that is over $1 billion, and it's at high risk of accidental failure because patients now monitor their blood pressures all the time. If you're on 2, 3, 4 drugs, patients are frequently monitoring their blood pressure now in a way that they couldn't in the 80s and 90s trials, and they're modifying their behavior and sometimes their drug adherence in response. And so I think it's extremely difficult to do a clean, cost-effective trial that delivers on that question. So we've just got to accept what the US FDA and the EMA accept, which is new hypertension treatments now. You have to prove they lower blood pressure with an off-med study, and then you have to show that the device is behaving as you want it to in much larger scale single-arm studies.
So quick question, quick answer now. So we have a couple of minutes left. You're talking as much as a French guy. Who wants to take this one? Redo in non-responders. So, Flavio, maybe?
Well, depends on what we consider is a non-responder. I mean, we say it's not responder if blood pressure does not drop at least 5. And this seems to happen in about 20% of patients. And this is perceived as a limitation. It is. We have to work on the identification of these patients. But if you compare this efficacy with other therapies, just to say one, the ablation of atrial fibrillation is much lower than 20%. And if you compare this with the management of stable angina in patients undergoing angioplasty, the failure is even higher than 20%. So I think we are in a good track, but we can do better than this. But compared with other technologies, I think it's very effective.
Okay. How to predict the best responders? Once you take this one.
There's only one predictor that turns out to be a predictor of response, which is baseline blood pressure. It's in part related to regression to the mean and law of initial values, so statistical phenomena, but also to an increased sympathetic activity. It's not very helpful clinically because we would expect larger faults in patients with high blood pressure, but it's besides high blood pressure, there is no single parameter that turns out to be helpful. It's not heart rate, it's not clearly any hormones that may be measured. It's not age. That was the question too. It's not age, certainly. It's not gender. So there is no clear cut.
Ethnicity, we have a question about interaction possibly in subset of population. Have you any comment about this? Is it more effective or less effective in for example, a black patient or patient from Asia?
So the long-term follow-up of Simplicity HJN3, which of course had a negative primary endpoint, but the subsequent 3-year reported data were more encouraging. There was data presented at an American conference earlier in the year by Deepak Bhatt, who ran that trial, suggesting that there was no differential between white and black race. And that it all settled down once those fluctuations in medicine that overwhelmed that trial had began to settle themselves down. So I think probably there's reason to believe that there's no difference in ethnicities, but this is an area that will undoubtedly have more study.
Last question, Rosa Maria, you want to ask a question to the panel? You want to challenge them with something?
Well, I think the most important question we have to ask ourselves is concerning patient selection. So in which patient do we really want to do this procedure? Now we produced altogether a document. We give we gave some indication to all the people. Do we think this is really the direction we have to take, limiting the indication to the resistant hypertension patients, with some exception, of course, in case of intolerant patients and so on? Or we see a larger application of this technique, given the data we have? I think this is the biggest question mark for me, still open. So very happy to discuss with the co-author of the document.
Well, I think we're going to explore that in the final section. So if that's okay, what we'll do is we'll move on to Flavio now, and then we'll come back to that. And I want everyone in the audience to think about who they would like to treat. So you have an app, you can send us messages, and Atul will look at them. As Professor Bruno has said, do we restrict it to the most desperate? Or do we start looking at this in different populations? Populations who are having recurrent heart attacks, whose blood pressure is 140. If we brought that blood pressure down by 5 to 10 points, that may benefit. So things like that, we'll talk about that in the next session. But first of all, Flavio.
Thank you, Andrew. Thank you, everybody, for being here and for this interesting place we are in. I would be very practical. I hope you may. I think we suppose many of you have never seen a procedure, so I will show you one. But before, some characteristics of the Medtronic radiofrequency catheter. I mean, it's a very flexible catheter. It goes in a 6 French guiding catheter. It goes from the femoral artery to the renal artery using a dedicated short catheter. Okay, it runs on a 0.14 inches wire, which is the regular wire we'll all use in coronary procedures. It's very easy to use, and it has a specific design where the electrodes are disposed circumferentially in the artery wall to irrigate the energy in 360 degrees distribution. It does not occlude the vessel, so the vessel is not overheating. There is not increment in blood temperature during the procedure, and the release of the energy lasts 1 minute. So these are interesting data for you to understand how it works. The radiofrequency creates heat, and the heat is the physical mechanism through which the nerves are destroyed. The heat distributes circumferentially across the artery, and it expands more easily into the fat, where actually the nerves are, without creating damage to the closed organs like the lymphatics and the veins. This is a graphic showing how it works. I mean, the energy goes up during the first 20 seconds. And you see that there is a heating of the artery wall, which goes up to 60 or 70 degrees. But the mechanism is set to keep it safe. So if the temperature is going too high, the electrode will be inhibited. Or on the other side, if the contact of the electrode to the artery wall is not good, so the heat is not sufficient, again, it will stop. So you can manipulate from a control you have in your sterile table each one of the 4 electrodes. As I said, the energy is delivered during 1 minute, but you can put the catheter in different positions, and you can do as many ablations as you wish. The mean number of ablations per kidney is higher than 20. So it's a very effective therapy in giving energy, and we think that this energy is going to burn the nerves, as Andrew said before, creating an irreversible damage where the neurologic fibers are being transformed into fibrosis. So as I said, it's a quite simple procedure. We have prepared this video for you to understand how it works. This is a setting of the cath lab. You have seen a 6 French introducer in the right femoral artery, and you should start with a non-selective angiogram of the aorta to see where is the origin of the artery. This is very, very useful to avoid wasting time and giving contrast, trying to find the artery selectively. This can be done with subtraction angiography with 10 cc's of contrast. These are important numbers because in our experience, a renal denervation can be done with less than 60 or 70 milliliters of contrast, which is very important, especially in general, because no human benefits from contrast, but especially those with impaired renal function. You see that the rate of injection is 4 milliliters to get this very nice selective injection, 4 milliliters. You can do this at the beginning, and if you wish, at the end. Since we are not concerned about safety in terms of vascular obstruction, dissections, or spasms that's resolved spontaneously, we don't check continuously the state of the artery. Just a final check to make sure that the artery is open. You see, this is the navigation of the 0.14 inches wire, which is a coronary wire. Sometimes you might need to use extra support wires when the vessels are tortuous. We don't recommend to do oblique incidences to understand that, because that means that you have to give more contrast. You know when the vessel is tortuous and you change your wire and you use an extra support wire. This is the generator, which is connected to the tip of the catheter. You can strengthen the tip of the electrodes to facilitate the introduction of the guide wire. And then this is how it looks. You see the 4 electrodes entering the guiding catheter. You can see it better. And you see the remote control with the 4 buttons to control the energy in all the 4 at the time, or you can select 1, 2, or 3 of them according to your planning. On the basis of the angiography, you will do a planning to decide where you will deliver the energy. So from the external part, a non-sterile assistant will turn the system on. As you can see, it's a rapid exchange system, like a coronary balloon. And you see how easily it advances, even in tortuous anatomy. This is a regular BMW wire. And after reach the position, we retrieve the wire, and this makes the curly shape of the tip that will expose the 4 electrodes in a circumferential way. Now we are ready to give the energy, so we press the button, click, and it makes a sound. And during 1 minute, it will be giving energy. What you see on the right side is the temperature. You see in between 57, 54 degrees centigrade and the impedance. After 1 minute, it will stop. You might be aware that during this, the procedure is very, very painful. So the patient needs deep sedation and analgesia, because it's not nice to have this pain. And if the patient moves, you may lose the contact of the artery and have to repeat. So you don't need to have the anesthesiologist in the room, but you need to have the patient very well sedated. Then it's the vessel closure. You can do it by hand or with angioseal or whatever you want. It is not important. The patient will be able to stand up during the same day, and the day after goes home. So going to real practice, I will show you one case that is one of the cases that convinced me that this therapy works. Because, of course, we need to be convinced about what we do. And it's a very special case, because I think it's the youngest patient ever treated with really resistant and uncontrolled hypertension. You see, the lady is 18 years old. At the time of the treatment, when we came to know about her, she was still not 18 years, so we wait until she was 18 to sign the informed consent by herself. As you see, she has a very long history of terrible hypertension, limiting her life, limiting also going to school, not doing sport. Although the lady was completely normal in aspect, she underwent any kind of screening to exclude secondary hypertension. You see, she did many MRIs, CT scans, PET, catheterizations of the renal veins. She was living in the south of Italy, and she was proposed to undergo renal denervation in a center in Rome. But actually, she was never called for the therapy, so her father found our website, which is a very effective way to be contacted by common people, and they came to Verona for an interview. And so we repeated all the examinations to include secondarisms, and we understood that it was essential primary resistant hypertension, despite this therapy that you can read there. 2 times candesartan, 10 milligrams of ramipril, 2 times 100 of atenolol, which I have never seen before, and amyloid, so 2 diuretics, and amlodipine 10 milligrams. Believe me, this is not a joke. And despite that, she still had hypertensive crisis with vomiting, seizures, and headache. She also suffered from a mild form of epilepsy. So this is the procedure. As I said, we start with 10 cc's of contrast. This is not this is not fluorography, this is fluoroscopy. So you reduce the dose of radiation. You see this is a skirt of lead on the genitals of the lady because very young. And you see the whole procedure was done in less than 1 hour. No cine and 55 milliliters of contrast with the 6 French guiding. 14 ablations on one kidney and 15 on the other kidney. This is again what you have seen before. Very nice artery, no stenosis, very rapid filtration. You see very rapidly, you see the venous phase and the cortex of the kidneys, just to show you exactly what I showed you before. One shot to start the procedure and to plan where you're gonna go with the, we may talk about this, we target the bifurcations, which is the main target of the, and we go to the results. So what happens with this lady? We follow these patients with ambulatory blood pressure, which is much more reliable than the office blood pressure, especially in these psychological conditions in which the lady and his family was convinced that she was really a very sick patient. Okay? And you see that there is practically no effect after 1 month. This is what we are used to see. And there was actually an effect after 3 months. But as you see, it's contrary to your expectations. The blood pressure went up. But we will see later why this happened. Then there is a clear effect at 6 months and an overwhelming effect at 12 months. This was confirmed both in the daytime and the nighttime measurements in the ambulatory blood pressure, which is very clear, and of course is one of the differences with medical therapy that depends on the pharmacokinetics. Well, this is independent because it's a 24 hours, as Felix explained, it's an always-on effect. And another overwhelming finding was the trends of the creatinine and the glomerular filtration rate. We start with a totally normal. You see creatinine is 0.7, but after 1 year it's 0.4. So we start with the GFR, which is 120, and at 1 month, it's almost 180. So even in a normal kidney, when you have better blood pressure control, you improve the renal function. And then a little comment on why at 3 months the pressure went up, because when she went home, when she went back home, the blood pressure was going down. So the general doctors retrieve medicines. This is something we don't do, because otherwise you don't understand which is the real effect. And actually, as you can see, all the mean pressures, day, night, went up. They put again the patient on the same therapy, and they went down. And there is another thing you don't know, that in between 6 and 9 months, she fainted because of extremely low blood pressure, and she was admitted into an intensive care unit because she had 70 millimeters of systolic and 50 of diastolic, but only because they maintained this terrible therapy. Now it's nearly 3 years of follow-up. She is living without symptoms with the therapy you see on the bottom part of the slide. So this is really one of the most impressive cases I've ever seen. Thank you.
Thank you, Flavio. I think when we have people set up their programs, that's not the sort of case we want them to start with. But it does really powerfully illustrate that if people are having seizures because of hypertension and then they're fainting because we've solved it and they're on too many drugs, I think that's a good thing.
While you are setting up the slides, a quick question for Flavio. In the first case, I think it's interesting because we had this discussion yesterday. It seems the lower pole of the kidney was not opacified in the first case, not in the lady, but in the first. You don't. And so he asked, there must be an accessory left lower pole artery. Did you engage, treat it? But let's say more generally, would you answer about how to manage accessory or pole artery?
These cases didn't have accessory artery, but when you do the angiogram and you see that there is a pole missing in the opacification, you have to look for it, because if it's a good target and has more than 3 millimeters, it should be treated.
Okay, thank you.
Okay, great. Well, this is just a discussion phase again. If anybody has any questions, then please come to the microphone or send them via the app. But this is the question that Professor Bruno posed earlier. So you put the question. I'll let you lead off. We've got this discussion document talking about it's reasonable now for patients who have a blood pressure over 140/90 on office, on 3 or more drugs, including a diuretic. If those are the definition of resistant hypertension, it is reasonable then to consider renal denervation if they fail to get to target. Is that sufficient? How big is that group? And would you like to go further or treat any other different patients?
So, as I told you, I think this is really the crucial point now, because now I think nobody has any doubt about the efficacy of the renal denervation in different settings of patients. We have the global simplicity registries with patients with different severity and with many comorbidities, with different degrees of renal function. And it's clear that it's really working in all this setting. We have all the sham-controlled, yes, exactly. And this is very clear. So with any comorbidity, we have a significant effect. And of course, in the global simplicity registry, most of the patients were resistant hypertensive because this is real life. But we have different kind of patients, and what Felix showed just in the first presentation was this. Even in individual with less drugs, the efficacy is the same. And it's the same with all the comorbidities you can see. But then we have all the randomized trials. And even in the randomized sham trials, we demonstrated that it's effective even in untreated patients, so patients with mild hypertension. And I think this is, of course, it was obvious in some way, but you can see really the evidence that is true. So the question is, in my view, we have to put some restriction, of course, for feasibility, because we cannot denervate all the people, all the billion of hypertensive people in the world. Just it's simply not feasible, and not as it's not what our healthcare systems want, probably. But we have to consider that it's a real possibility, and I think even cases like the extreme case that Flavio proposed just now, of the young lady, we have to consider that it's true that even in the young, a large percentage of young hypertensives are essential hypertensives. Because we are taught we have to look for secondary hypertension in all the young people with hypertension. But then the pediatric case series, even under 18 years old, half of the hypertensive people is essential. So it's really important to have tools that can help us in different conditions. Of course, this was an extreme case, but it's true that it's something that we should really discuss case by case, and not, how can I say, our limits are really of feasibility and of reimbursement, in my view.
Yeah, I mean, that case that you showed had been through 2 professorial hypertension units in different parts of the country, right? They'd had every test known to man. So that's an unusual case. But we are faced with legions of patients who have blood pressures 150, 160 on 2 drugs. So I told Felix, any comments? I mean, are we going to stick with this resistant hypertension cohort who are beginning to run out of options? Or do we look to expand the cohort? What are your thoughts?
Okay, I mean, from a very practical perspective, when you see a patient, RDN should be part of our software.
Yeah.
Okay, so when you see a hypertensive patient, you need to go to different options, and we need to assess now that any patient could be a candidate for renal denervation, which is an option to reduce blood pressure. It could be an alternative. It could be as the only option you're offering to the patient. It could be on the top of treatment. So I think the complexity of the question is that we are fighting against what we believe is good for the patient and what we are allowed to do. What we think is good for the patient, not what is reimbursed. Okay, so and we had this type of question of how to promote the reimbursement of the therapy in my country. I think I'm answering directly. Whenever I see a hypertensive patient, from the young one to the old one, I will think now and I will talk also about renal denervation with the patient and the physician as an option.
Yeah. And Felix, are you happy we have enough safety data? We've got safety data from the Ray Townsend meta-analysis in neurointervention. 20,000 patient years have undergone RF, 8,000 patients, 20,000 years. Is that enough? I mean, especially when we're talking about unique cases, but if patients could be encouraged to go on to multiple drugs from the age of 40 to the age of 90, should we just accept that that is still the standard of care for the coming decade? What would we need to try to change the paradigm?
That's a challenging one, I guess. It is safe. What we have seen in studies and in registries indicates that it is associated with very low adverse event rates. But the more we do, the more cases we will see where things are happening. I mean, that's what we're doing, right? We're interventionists, and anytime we do something, there is also a chance, may it be very low or even lower than very low, but there is a chance of a complication, right? And this is something that we have to face. So whenever it comes to a procedure, to a device, to a drug, we have to talk about risk and benefits to patients. The benefits are clear. We've shown it. It lowers blood pressure in most of the patients, and the risks associated with the procedure are also low. But don't forget, the meta-analysis data refers to patients on drugs. Most of them had resistant hypertension. And here the indication is pretty easy because you're running out of alternatives. In an individual that is untreated, you have various approaches to get the blood pressure down: lifestyle modification, antihypertensive drugs. So I think it's easier to stick to patients where one of those failed, or patients who express a strong preference to be treated with an alternative approach such as a device.
That's why I think the document we all contributed to, the ESC-EAPCI clinical consensus statement, I think puts it together well. If you have uncontrolled resistant hypertension, having been treated with 3 or more drugs, including a diuretic, with relatively preserved renal function, then I think it's acceptable to think about denervation for those. There's so many of those. I think personally we should focus on those first. And then if you have, we've all met them, the 65-year-old lady who can't tolerate any antihypertensive drugs and has ambulatory blood pressure of 170. I think it's wrong to exclude those. And if you try and get them to go on 3 drugs at once, they will not take them. So I think there's enough of those patients out there for us to begin the field. But I think you have some more questions.
Yeah, also maybe not directly related to this section, but to all of you who are interventional cardiologists. So first, how many ablations do you suggest per procedure?
So Flavio?
Well, it's important that you make a planning according to the angiographic aspect of the vessel. We have to target the main bifurcations, and then the bifurcation itself, and the distal part of the main shaft of the artery. So it's difficult to say because anatomies are very different. Then you have accessory arteries that may deserve to be treated, but it's a mean of 15 to 20 ablations per kidney, more or less.
Okay. Any comment about sheet management after procedure and also anticoagulant to use heparin reversal, heparin, aspirin?
It's a 6 French guiding, so you can do manual compression or using a dedicated closures device like in any procedure. And regarding the anticoagulation, very important point, we give heparin, we give aspirin before, and of course intraprocedural heparin like in any endovascular procedure. We don't continue any kind of antiplatelet or anticoagulation unless there is an indication for other reasons.
Okay, what I'll do is I'll step on to one of the ones we've planned, because this is a question we get asked all the time, Flavio, and I know you've got some experience and some data in this.
Yeah.
So chronic kidney disease, the trials have excluded patients with very low GFRs, but you have a bit of experience where there's significant unmet clinical need, and so you've treated some patients within a registry environment. Tell us about it.
Well, you have seen in the previous slide that CKD with a GFR below 40 keeps on being a contraindication. But I have to say, why we started treating patients with CKD? Because the most faithful partners we had in our center to refer patients were the nephrologists. And among these patients were also patients in dialysis. And so we made this experience. And we have to consider the patients with renal failure are very high-risk patients. If they are hypertensive, they are very high-risk patients for vascular events. So this is a good reason to treat them when they have uncontrolled hypertension. And the other reason, and this is something we're working on and we have learned from our nephrologists, is that the renal denervation, be it by reasons we don't know, that has to do with the antiadrenergic effect of the therapy, be it because you have a better blood pressure control, preserves renal function at the long term. So the expected decay of the GFR on time, which can be calculated in healthy people or in people with depressed renal function, it's better than expected when you obtain better blood pressure control and likely for some effects that we still don't know related to the renal denervation. So we do believe this is a population that should be reconsidered when the therapy will be accepted worldwide. It's a population that might benefit even more than the rest.
And to add to your point, pathophysiology is in favor.
Yeah, that's very strong.
It's a very good model of sympathetic overdrive. From a pharmacological point of view, we struggle.
It's difficult.
Blood pressure because some drugs are eliminated by the kidney. You cannot adapt or you cannot use them. They have arterial stiffness. They have calcification. You have interaction. You have huge blood pressure variability when you look at the EBPM. So I think for many reasons, these patients are good candidates.
These are your results, Flavio. How many patients are we talking about here?
Well, we published a paper with the first 40 cases. And now we have many more and we have longer follow-up. So we plan to publish this next year with an update of this data.
No, I think in the new spiral affirm registry that is starting, we will include patients also with lower GFR compared to the sham control trial. So soon we will have also many more data probably on this topic, and this will be very important also because just to stress that these are always resistant hypertensive patients, and the spironolactone cannot be used in most of them.
Difficult to control.
Yeah, you see that the effect on blood pressure lowering was the same in patients with normal or with reduced CKD, and at 1 year we found no change in the renal filtration rate, which had been expected instead.
Okay, so what we're going to move on is to the final section. We are going to get patients. We've got 6 sham control trials in the space. We have more data on a sham control basis than any other device in cardiovascular medicine. Well, I think that's fair to say. Patients are going to get wind of this and they're going to come to us and they're going to say, I would like this procedure. I don't want to take drugs for 20 years. And our consensus statement has advised against just open access. They've tried to restrict it. So Atul, you're an expert in exploring patient motivations and shared decision-making. Tell us how we're going to handle those consultations.
First, everybody do not want renal denervation.
No.
Okay, from our survey, we believe that everybody wants, but it's not true. So when you do a survey in Germany or in Japan and you just ask a very simple question, what do you prefer, renal denervation or medication? Let's say that globally, 30% of the patient will say, well, I'd rather go for renal denervation. So this is the first very important message, but it's still 30%, is a lot. Okay. Second, what is driving the process? The major driver is blood pressure reduction. What patients expect from us is to offer them a solution which is able to reduce blood pressure. And I think that we have now data quantifying that patients are even ready to accept a procedure with a tiny effect on blood pressure, sometimes even lower than what we have in trials, which is surprising. So they're ready to accept a 2, 3, 4 millimeters mercury of decrease. And they're even ready to accept it for some level of risk. Okay? So it's very interesting. All patients are not ready. What is driving their decision is blood pressure reduction. But when you look at the benefit-risk ratio, they are, I think, more tolerant to risk and ready to go for procedure, probably more than physician. I mean, if you, for a same patient, you will ask the physician and the patient, you will have different type of answer because we know that physician will rather select patients who have very elevated blood pressure and a huge drug burden. So still the drive to go and treat those who are very complicated, while patients are ready to go for the procedure even for a tiny effect and even with some level of risk.
So how do we handle this? If somebody comes in and says, my blood pressure is controlled on one drug, I wanted to have this procedure so I can come off the drug.
Yeah,
what are we going to do?
You have to be honest. Okay. I mean, you will not cure their hypertension. You will modulate the management. You will optimize the treatment. You might maybe reduce one drug, but you have to be fair. They are non-responders. The therapy lowers blood pressure. It might control it, but it's not something which will solve totally their problem. But it's part, I think, again, of the process, because we never have this discussion with drugs. You never ask a patient, do you want an ACE inhibitor or an ARB? Are you okay with the blood pressure reduction of 5 milliliters with the calcium channel blocker? If we stop the calcium channel blocker, do you want us to replace it with the beta blocker? We never have this discussion. You take your pen, you say, okay, your blood pressure is not controlled, and you write. So why are we doing it with renal denervation? Because it's a procedure, but I think it's also giving now more space to discuss about options with patients.
I think it's important. And patients listen very carefully to the people who are referring them to you. So this brings us on to the final section, which is networks. So Felix, you've built as big a network as anybody. Bearing in mind we've just got over a minute and a half. How do we set up these teams to get responsible referrals and delivery of service?
Very briefly, you need a team, as said here. So rightly, it's multidisciplinary. It should involve non-interventionalists for sure, internists, nephrologists, pharmacologists, everybody who's taking care of patients with hypertension. And then importantly, you have also to involve patients, preference in your decision making. This is of utmost importance, and don't denervate everybody that is referred to you, because that speaks to your credibility. I guess when you refuse patients' wish for the right reasons, then that will increase confidence in the referrer that you are the right person to be approached with difficult to control hypertensive individuals. I think that's, in a nutshell, what I would recommend.
I think the multidisciplinary team is at the heart of the consensus statement. We need to emphasize that you don't take a patient for your own practice, denervate them yourself, follow them up yourself. We need a team. So Atul, I'm going to let you wrap up. We've got 40 seconds to summarize, and then we're going to sign out.
It's very easy. Do it. Just do it.
Yeah, we're ready now, aren't we?
We are ready. The beneficial effect of the therapy has been proven. The benefit-risk ratio is in favor of the therapy, but also the follow-up data. Flavio has nicely shown how to perform, and I think for interventional cardiologists, it's something you can learn, you can be proctored, and I think it's something which can be part of your armamentarium. We discussed, I think, with Rosa Maria, some issues regarding patient selection, patient profile, and also the interaction with drug therapy. And again, RDN could be an alternative or proposed as something on the top of treatment. And finally, I think we need to work together. And with that, I would like to thank you for your attention and hope you will enjoy the meeting this afternoon.
Thank you, everyone.